Yeah. Before we start the session, I would like to give a brief introduction about you and about the platform. Okay. So, good evening, everyone. This is Krishna Priya from MedWorld Expo. MedWorld Expo, as you can see, it's an unified digital healthcare platform connecting manufacturers, distributors, hospitals, clinics, laboratories, and healthcare experts worldwide, like Dr. Urvashi here. It's an honor to introduce today the distinguished speaker, Dr. Urvashi Tanwar, an enthusiastic, passionate, and career-oriented professional, and the proud owner of Ashriya Dental Care at Panchsheel Enclave, Delhi. She completed her BDS from SDM Dental College, Dharwad, where she was awarded the gold medal, and went on to pursue her masters in conservative dentistry and endodontics from Dayananda Sagar Dental College, securing the second rank in Karnataka. That's a huge achievement, Dr. Urvashi. Uh, she has been recognized at various national and international conferences with multiple awards, and she regularly contributes her clinical expertise to dental magazines through published case reports. Trained in biomimetic dentistry, she is deeply committed to preserving natural teeth, combining advanced techniques and state of the art endodontic procedures to deliver the best outcomes for her patients. Her dedication to the excellence goes beyond conventional dentistry, whether it's root canal treatments, restorative procedures, or preventive care. Dr. Urvashi strives for perfection in every case. She truly embodies the spirit of conservative dentistry, ensuring patients receive the highest standard of care while preserving what nature has given them. Please join me in warmly welcoming Dr. Urvashi Tanwar. Over to you, Dr. Urvashi.
Thank you so much, Doctor, for this wonderful introduction. And I would also like to thank MedWorld for inviting me and allowing me to share my expertise with everybody so everybody can have a bit more to learn from. I hope my
It's
audio is clear.
it's
I
very clear, and it's
okay.
our pleasure to have you here, Dr. Urvashi.
Thank you. Thank you for
Of
having
course.
me. I'll start to share my screen now. And for
Yeah, we can
my,
see your screen. You can start.
is it visible now?
Yes, yes, it's visible.
Okay, so for my participants, a very good evening. Thank you for joining me today and giving me a bit of your time to try to learn endodontic diagnosis and the complications that come with it. I would request everybody, if they have any one particular doubt that they have been facing with their diagnosis, especially related to endodontics, I want them to please put that in the chat box so that we can address that if we leave that out once the webinar is over. And we'll try to see if by the end of this webinar, most of them are answered or not, that. And for a special prize for those who stay till the very end, there is a special surprise for those participants as well. So stay tuned for that. Okay. So again, good evening, everybody. Today we are here to discuss the root of the matter, elevating diagnostic skills in endodontics. And let me start with a very quick story. A young patient once walked into my clinic with a severe toothache. She had already seen two dentists by then. One had advised an extraction and the other suggested a root canal. Now, both seemed logical, but only one was correct. And what makes this difference is the diagnosis. In endodontics, the file system or the obturation technique doesn't decide the outcome, but the accuracy of the diagnosis does. And it is what helps us choose whether to treat, when to treat, and how to treat. And today we are going to dive into this detective work, reading the patient's history, interpreting tests, correlating the radiographs that we take, and then bringing it all together into a confident decision. So let's get started and unlock the true foundation of successful endodontics, which is the power of a precise diagnosis. For those who don't know me, I'm Dr. Urvashi, restorative dentist and endodontist by training. and a passionate advocate of minimally invasive dentistry. I run my own practice, Ashirya Dental Care, in Delhi, where we focus on predictable, long lasting, and aesthetic dentistry with a special love for rubber dam isolation and bonded restorations. Teaching and sharing has always been my happy space, so I'm excited to be here with all of you today. Now, today we'll be discussing the entire webinar under 4 broad headings, which is the diagnosis, why we need it, what is so important about it. Second would be SOAP, which is how would you document this diagnosis? I'll teach you ways. I'll teach you what all entails it, and then I'll show you a sample of how you should do your own endodontic diagnosis. Then we'll look at a few cases and try to learn diagnosis through those cases. And finally, we'll conclude it all to wrap it up and summarize it in a nice way. So by the end of this lecture, you will be able to learn the importance of correct diagnosis in endodontics. What is pulpal diagnosis? What is periapical diagnosis? What are the diagnostic protocols that we have and the tools that we use in order to come to the right diagnosis? And then what kind of treatment planning is done based on the diagnosis? Okay. So let me start with the case. This patient was a heavy beetle nut chewer, and he came to me saying that this particular tooth has been paining for the past 1 week. The pain is very severe in nature. It is electrifying, that sort of pain he's having. And it is especially more when he drinks something cold or is eating sweets, especially. He described it like that. When I looked at the patient's tooth clinically, I could see that the tooth is heavily cracked, and not just this tooth, as you can see, the tooth behind it, in front of it. And in fact, all his posterior teeth were heavily cracked because of the beetle nut chewing that he had been doing. Okay. Now, because I noticed this crack, I told the patient that we would need a CBCT in fact to know how deep these cracks are going, So he had a temporary filling in place, which somebody had done. I'm not sure. Even he does not remember what was done exactly. And I asked to just remove this filling and see. And when I removed this filling, I saw a very deep mesiodistal crack. Now, we all know how dangerous mesiodistal cracks are, because most of the times they are going, all the way down to the root of the tooth, usually splitting the tooth. So that is why mesiodistal cracks are very dangerous and notorious to treat. So when I saw this, I had my danger sign up in my head, and I was like, I need to know how deep this crack is going, whether this tooth is salvageable also or not. Okay. Not every time. What I'm trying to tell is that every time a patient comes to you and he's giving you typical symptoms of pain and irreversible pulpitis, it does not mean that you pick up the drill and start drilling and doing root canal, you start explaining. No, because cracks are so difficult to treat, and their prognosis is so poor depending on which stage of the crack development that you find them, that even if you do a good root canal, it's not going to save the tooth. Okay. So it's very important for you as a clinician at this point, in order to make the right diagnosis that will save you from embarrassment later. Because if this turns out to be anything different, and if the symptoms are not treated or the symptoms are not gone after your treatment also, the patient is going to blame you. The patient is going to ask you questions, and that is when you're going to go back and be like, okay, this is where I went wrong, and it is nothing but the diagnosis. Okay. So when we did a CBCT, we could see that the crack was going all the way from the occlusal surface down to the furcation. Okay. I told the patient that this tooth is not going to last long, and I cannot tell you how long it will last. Okay. We have the first option, if you want to have something that is long lasting, would be to extract this and place an implant. The patient was not ready for it mentally. They told that, is there any other option? They asked me if we want to save this tooth and all those things. I told them the prognosis looks bad because the crack has gone fully deep, and it's a through and through, fracture, and it's going to like crack anytime, it's going to become develop further, and it will break the entire tooth apart. Okay. The patient was insistent, so I told them that I can give root canal a try. It might work, it might not work. We don't know how long this tooth will last. It's going to split ultimately. Okay. And I took an informed consent at this point. I've written in the consent that this is what we are doing. I have explained to the patient, and the patient signed on it. He knew fully what he was going to do. And we went ahead and did the root canal. When I opened up the tooth, we found 4 colors, and the tooth was heavily necrotic. In fact, there was a lot of pus drainage that came out. I finished the root canal, everything was done. Also gave a cuspal coverage for all 4 cusps for this tooth. The patient comes back to me after, I think, a month or two with severe pain. And I told them, see, I told you that this is going to happen. Root canal might not take care of the symptoms and all that. We took a CBCT and we saw that it had cracked, in fact, my cuspal coverage also, and gone all the way through to the focal involvement. And then this patient finally then agreed that, okay, now we can get the tooth extracted. My point here is that if at this point you had not done a good diagnosis and not taken informed consent, the patient could come back and tell you that the tooth is still paining, and you would be like, you don't know why, right? So we took a CBCT before, we took a CBCT after, we had an informed consent in place. Everything shows that we did right by the book, right? And the patient was also very comfortable. He knew in the back of his mind that the doctor had already told that this would happen. The patient is angry and more fearful when the patient was told a certain thing and then something completely opposite happens. That's when the patient becomes, you know, more anxious and does not know what to do. When you inform the patient that this is what is going to happen and this is how, this tooth will proceed, the patient is more relaxed and is like, okay, the doctor told me, and that is when they trust your knowledge and your expertise even more, right? So why is endodontic diagnosis and documentation so important? I want you to consider the following scenario, okay? Like, if there is a patient who has been told that this particular tooth needs a filling, and you do the filling, and then the patient comes to you the next day upset because she was not able to sleep last night due to severe pain that began after treatment. She was told that the restoration was deep, but the pain should have resolved on its own. The patient is upset. She does not understand that when a filling was needed and the filling was done, why is there so much pain after the procedure, than before the treatment, you know and then you read the notes and you see that another associate dentist, in fact, at the office, has written that this tooth had irreversible pulpitis and symptomatic apical periodontitis. Okay. Now, the patient is already informed that the tooth will require root canal and a new indirect restoration. The patient is again upset now. Ki why was the RCT not told before itself and was not initiated yesterday? And now questions ki if it is only necessary now because something that was done, maybe something went wrong in the first treatment. So now, as I told you, when the treatment is going in a certain way that was not predicted by the dentist or the doctor before, or not told that this would happen, now they're starting to question everything. They do not trust what the treatment was done, they do not trust your expertise, everything. you know so when you look at the notes and everything for more information for what tooth was done, how the symptoms were, you barely see anything. So basically, there's no documentation of her symptoms, there's no objective evaluation to establish a diagnosis for the patient who presented with probably mild pain, and the associated tooth had a very large carious lesion, and there's no documentation of what exactly were the symptoms, because now there are two doctors and they're telling different things. But the end result is that you have an upset patient at your hand and you need to deal with this situation right now. you know this is why diagnosis and its documentation are equally important. So what are the diagnosis objectives? One is to reproduce the chief complaint. Whatever diagnosis you've made, you should be able to reproduce the exact same chief complaint, that this is what is happening. Next, you have to determine the cause of the chief complaint. And the third thing is that whatever treatment you do must eliminate this cause, right? Like in the previous case that we had a crack, okay? Now, root canal does not eliminate the cause, right? Because the crack will go deeper, it will bifurcate and it will break the tooth apart. And then the movement of the fragments every time the patient bites is going to cause pain and sensitivity in the periodontal apparatus, right? Earlier, he probably was having some sort of irreversible pulpitis, and which is what led to the necrosis of the pulp. And, end of the day, we had a necrotic pulp, and then we did root canal for that, sure. But the cause was the crack. The crack carried all that microbiome everything inside caused the pulp to turn necrotic. So the cause was the crack. And we know we cannot eliminate the crack completely. It is going to go through and through. We cannot do anything about it. We saw the pre-op CBCT. So we could not. The only way to eliminate the cause is an extraction. But what did we do? We did a root canal. And that is why the pain returned. So that is why diagnosis is very important. Okay. And this is where this protocol, the SOAP protocol, comes into being, right? So what this helps us is with the diagnosis, it's also and how to document this diagnosis also. Okay. So S stands for subjective, O stands for objective, A is the assessment basically of whatever you have been able to collect from the patient and then come to a diagnosis. And P is how to plan your treatment after you've received the correct diagnosis. And all of this in turn helps you to document it as well of a particular tooth. Like in the previous example that I told you, the patient was treated by another dentist and then they're coming and telling you that this happened, that happened, but there's no proper documentation. You can never figure out what had happened to the tooth previously. That is what is so common nowadays. You know, even if you in the same clinic, there's no documentation. It is only about how much they remember. But we need a proper documentation for the endodontic diagnosis as well. So we'll deal with each and every letter individually in the acronym, where S stands for subjective, which is nothing but the subjective data or the chief complaint. So this is defined as basically having patients describe the signs and the symptoms in their own words. This is very common. We've been, hearing this since our BDS days. Since the treatment is centered around the specific patient, your SOAP protocol or the note that you're going to make, I'm talking about the documentation now. It will begin with this subjective information only. I'll show you after I explain to you what SOAP is, how to write the document as well, how you will write each endodontic diagnosis, okay? I'll show you an example, but just for now, just hear me out. So the starting of this note, the documentation will start with the subjective symptoms, which is nothing but the chief complaint. It will also include some sort of past, present history of the illness, as well as any other significant dental history that they might have. So this is recorded in the patient's own words. Try not to lead the patient. Don't ask, do you have this, you have that. Just let them speak first. What you can ask is like, what brings you here today? What is the problem that brought you in to see me today? Let them speak and address the problem and listen for endodontic versus non-endodontic issues. Okay, don't just sit there in a blank form. Start thinking whatever they're telling. Like suppose spontaneous or lingering pain is associated with irreversible pulpitis. Pain that is described as burning electric is not of odontogenic origin, but throbbing sharp or dull pain is typically used to describe pain of odontogenic origin. So this is how we are differentiating. As the patient is telling me, there is so much that before I even start my clinical evaluation, I have heard so much from the patient, the history, the past illnesses that they've had. I'm able to, slowly funnel everything out and come to a diagnosis in my head, provisional diagnosis of what this is probably sounding like, you know. So answers to these questions will help me form an initial diagnosis and plan the objective tests to be performed. I'll know what exactly I need to perform to even, come to a more specific diagnosis. So one of the goals of objective testing is actually to reproduce the patient's symptoms that I told you, right? But the subjective data is the starting point. So even if a patient reports like only mild or fleeting pain, then your objective tests are necessary to arrive at a diagnosis because you don't know what you're dealing with. Okay. So S is subjective. How long have you had the problem? What is the intensity? What is the frequency of pain? What triggers it? What relieves it? How long does the pain last? If an asymptomatic patient presents with a very deep carious lesion, then the status of the pulp and the apical tissue should be evaluated prior to caries removal, because often we know that necrotic teeth are asymptomatic. But if you do objective tests, they reveal pain to biting, right? So diagnosing prior to treating results in a more efficient and effective care. Although the need for an endodontic procedure may be determined after caries removal, it is still advantageous from a professional and patient management standpoint to anticipate the required treatment before initiating therapy. Please, this is very important. Often we are too vigorous and very eager to start treating the patient immediately, start doing the root canal. But please take your time, because the treatment may change as it progresses, but the initial diagnosis, the approach should be, supported by the original diagnosis only, because you should not be going in blind, like, okay, I'll see what is happening and what needs to be done. No, please, you need to have an idea beforehand. Okay. So the details of the symptoms you can have: location, severity, nature, frequency of symptoms. All this is very common, but we forget. We do not ask all these things. I'm just trying to emphasize that we should. About the history of pain, when did it start? Has it progressed? Details of the symptoms. Ask about the specifics of pain. Is it throbbing? Is it burning? Is it shooting? Is it very sharp? All this will guide you. If you have something very sharp and spontaneous pain, you're dealing with something pulpal. If you have like a gnawing type of dull throbbing pain, you're looking at something periodontal. So moment you start asking these detailed questions, you will already start to form some sort of provisional diagnosis in your own head, and then your objective tests are just going to confirm it. You also have frequency and triggers, like is it spontaneous or triggered by specific actions, the stimulus of pain and duration, like with cold, heat, sweets, anything. How long does it last? Immediately disappears, so we know it's in a reversible state. If it does not, it lingers, we know it's in an irreversible state. And this thing exactly, we're going to reproduce it in our objective test. So we are going to reproduce the chief complaint by doing a cold test, right? So we'll do the whole thing again. We'll put cold on the tooth and we'll try to reproduce the chief complaint, right? History of the pain: how did it start? How did it progress? Biting sensitivity from malocclusion or a periodontal problem. All this you need to ask, okay, in your subjective evaluation. O in the SOAP represents the objective information. It is a result of observations as well as tests that are conducted by the dentist. These tests will usually, but not always, correspond with information obtained from the patient itself in their subjective history. So the objective examination includes clinical exam, the tests, and the radiographic analysis as well. For extraoral and intraoral examination, you have to look for signs of swelling, asymmetry, any discoloration, palpation of the lymph nodes, check for tenderness, enlargement. Intraoral findings, we all know: examine for asymmetries, swelling, redness, inflammation. Check soft tissue findings, do your oral cancer screening, look for wear facets if it indicates, strong occlusal forces or parafunctional habits. Note down any recession, exposed dentine that could indicate reversible pulpitis, Then look at the endodontic disease causes. Look for the cause of this endo that you might be dealing with. Bacteria can get into tooth areas of recession. Tooth fractures are again another area for bacteria to enter the pulp. So use magnification, use a probe to check for fractures. If you need to use transillumination, do that. Do your clinical testing, do your probing, measure at least 6 points around the tooth and look for isolated pockets with sudden probing depth. This is what it looks like. If you are probing a particular tooth and you have a sudden probing depth, a probe going suddenly very deep in one particular point, which is an isolated, narrow, but very deep periodontal pocket, it almost always tells you that there is some sort of crack in that area or there's a fracture of the root. It's a very common sign. And if you take a CBCT, the way to evaluate the exact same thing on a CBCT would be that on an axial section, you will see just around one particular root, you will see bone loss because of this, So isolated bone loss, isolated pocket, always a crack. Coming to cold test, I already told you the patient's interpretation of the sensation is very subjective. So you need very clear guidance and explanation needs to be provided. So for example, patients should be asked to indicate it when they feel a sensation with the cold test. Don't ask them when you feel pain. Ask them when you feel anything, because some patients are like, okay, even if it is paining or something, they'll not tell it as pain. Even sensitivity, they'll be like, no, 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 there's no pain yet, right? So make sure you tell them that you need to inform us immediately when you feel anything, Again, with the duration of the pain stimulus, if it's less than 30 seconds, it is in a reversible state. If it's more than 30 seconds, it's in an irreversible state. Three things that I want you to remember when you're doing the cold test is that you need to shake the bottle really well. Second thing, that the cotton has to turn frosty, and make sure that you've isolated the arch very well, and you will test on a contralateral tooth, on a normal tooth, for the patient to be able to know what is, early or lingering. They wouldn't know that, right? So you will test this on a normal tooth first, because this 30 seconds of reversible, irreversible does not work for everybody. So you always test it with the contralateral or the normal tooth in the patient. So have a control, basically. Three things: shake well, needs to be frosty. The cotton has to be frosty because otherwise the cold isn't cold enough, and always have a control. Next would be the bite test for cracks. So we've already done the cold test for endo. You will get most of your answers with this particular test. But for the bite test, I already told you that this is something that we use as a tooth sleuth to detect cracks. Okay. And this is how we do it. Just look at the video.
For a cusp there. So I'm going to show you, I'll talk Dr. Ashley how and through how we should do the tooth sleuth. And you can actually use the same dialogue for when you talk your patients through it, right? So I say, all right, Dr. Ashley, I'm going to go ahead and see if the tooth is correct. We're going to use this to push against all of your tooth cusps, okay? We're going to test each cusp specifically. And all I need you to do is leave this
touch each and every cusp and test it individually.
Just until you make tooth contact with it. Once you're in place and you're lightly biting down, I'll ask you just to clench for just a second. And as you clench, I'm going to wiggle it around. Okay. So we're going to go ahead and test the buccal cusp of number 20.
So they're testing the buccal cusp of mandibular molar.
Contact here. There you go, nice and light. And now I confirm that we're in position. I'm not pinching her lip. I'm not pinching it against the tooth loop. Okay, we're good. Dr. Ashley, go ahead and clench. And as she clenches, I'm going to wiggle this around and go ahead and let go. So we do it like that. And then I say,
in case you want this video, I will share it with everyone. You can watch it how a tooth sleuth is supposed to be used. Okay. In case you don't have this, an alternative would be to take this cement spatula and wrap it with cotton and then test individual cusps. So that it's a bit difficult, bit tricky, but I've realized that it usually works well. It gives you a good idea. Okay. So also I wanted to tell you that something like this, when you see on an x-ray where you have a periapical lesion, it does not always mean that the tooth needs endo. Okay. So when you see radiographs, don't immediately jump seeing a periapical lesion to endo, because a periapical issue could also be due to bite issues or other factors. So don't think of endo immediately. So x-rays are very important. The third thing is A, that stands for assessment. So basically your diagnosis based on the clinical data, and it consists of a pulpal and a periapical diagnosis. So pulpal diagnosis is your clinical condition of the pulp as evaluated by your Cole test, your ICE, electric pulp test, and other things. But the periapical and the periradicular diagnosis is the clinical condition of the periapical tissues as evaluated by biting, palpation, and percussion tests. Okay. So let's look at pulpal diagnosis as given by AAE. That is what we're going to follow. Basically, there are 7 types, and we'll discuss each in detail. The first one is a normal pulp, which means a clinical diagnostic category in which the pulp is free of symptoms and normally responsive to pulp testing. It has no issues. Okay. The second is reversible pulpitis. Now, a clinical diagnosis based on subjective and objective findings, indicating that the inflammation should resolve on its own and the pulp will be returned to normal, condition to that the original causative symptoms are removed. Okay. So reversible pulpitis indicators are no sensitivity to percussion or bite and potential cold sensitivity. Okay. So basically non-lingering type of cold sensitivity that they have, non-lingering thermal tests and non-spontaneous pain. Everything is under reversible pulpitis. I can share this article with you in case you want to go, read it in detail. Right now, I'll just tell you in short, you might forget it. So you might need to brush it up when you're doing the soap thing on your own. Okay. Next is your irreversible pulpitis. And in irreversible pulpitis, we have 2 types, which is symptomatic and asymptomatic. And symptomatic is basically indicating a vital inflamed pulp, which is incapable of healing. So it has lingering thermal pain and it has spontaneous pain or referred pain. Okay, basically it has gone to that irreversible stage, but it's symptomatic. The patient is complaining of pain. In asymptomatic, basically there are no clinical symptoms, but the inflammation that has been produced by caries excavation or trauma, anything has progressed far enough to cause irreversible pulpitis, okay? So this is asymptomatic. The patient does not respond to it, but you know that the pulp is dead, you know. The next stage after asymptomatic would be pulpal necrosis, you know. This indicates the death of the dental pulp and the pulp is now not responding to any sort of pulpal testing. Next would be previously treated. If you see a tooth on an X-ray where you see the root canal has been already done, so the diagnosis you'll have to write would be previously treated, which means it has been endodontically treated and the canals are obturated with some sort of filling material other than intracanal medicaments, okay? It's not going to be any intracanal medicament. It has to be a permanent filling material. Then only you're going to write it as previously treated. Last is the previously initiated therapy, which means that you see the tooth has been previously treated, which means they've started endo treatment, but they've not finished it. Maybe it has a pulpotomy or a pulpectomy, or there's some intracanal medicament, or there's nothing in the canals, but there's an access opening. So basically it is previously initiated therapy. Somebody has started it, but they've not finished it for whatever reason that is there. Those are the pulpal diagnosis. Now we are coming to the periapical diagnosis, okay? So the first one is, again, normal apical tissues, which means that teeth with normal periradicular tissues, they are not sensitive to percussion or palpation testing. And the lamina dura, which is very important, surrounding this particular tooth is completely intact and the periodontal ligament space is also uniform. These are the two important criteria that we have for normal apical tissues. Now, in symptomatic apical periodontitis, you have inflammation, usually of the apical periodontium, producing clinical symptoms including, you know, a painful response to biting or percussion or palpation. It may or may not be associated with the radiolucency, but when you palpate or you're percussing, probably the patient is having some sort of pain. Next is when you come to asymptomatic apical periodontitis, which means inflammation and destruction of the apical periodontium has happened because of pulpal origin and it appears as a proper apical radiolucent area, but it does not produce any clinical symptoms, okay? Next is your acute apical abscess, which means there is some sort of an inflammatory reaction to the pulpal infection and the necrosis has happened. Now, this is characterized very typically, you know, with onset and spontaneous pain. It is very fast. The, you know, like you have like those phoenix abscesses, those are acute apical abscess. You're going to have severe pain, rapid onset, spontaneous pain happens on its own. The tooth is tender to pressure. There's a lot of pus formation, there's a swelling associated with the tissue. So this is an acute apical abscess. Next one would be very logical, chronic apical abscess. So the inflammatory reaction to the pulpal infection and the necrosis, it has a gradual onset. There's little to no discomfort and there is intermittent discharge of pus either through a sinus tract, you know. Now because of the sinus tract, because it is acting like a relief valve, it is relieving all that pressure, you know, so it does not allow it to build up. So the patient does not experience pain. So chronic apical abscess is usually very asymptomatic. And the last one is condensing osteitis, which is nothing but a diffuse radiopaque lesion representing a very localized bony reaction to low-grade inflammatory stimulus, which means continuously, if you keep it, there is a lot of insult to the pulp and the periradicular area, but in a very gradual way. Continuously, small insults will lead up to this situation where you have a very localized, you know, radio opacity. You know, it is seen at the apex of a tooth, and you can read up more about this, but there is a diagnosis, the last thing, which is the condensing osteitis in periapical diagnosis, okay? Now we look at some conditions which mimic endo pain, but it is not endo related, okay? So one is acute periodontal abscess and other periodontal problems. We need to distinguish this from endodontic issues because we cannot be doing endo for everything. Acute and chronic sinusitis. Now we know that we have two maxillary sinuses here and the roots of our posterior teeth end up giving indentations into this maxillary sinus. So the sinusitis can actually put pressure on the roots leading to dental pain. So if the patient comes to you temporarily with some sort of pain in the posterior teeth, but you don't see anything clinically and you're not able to reproduce the chief complaint on your own, you can ask the patient if they have some sort of cold or they have sinus issues. And if they say yes, you're going to monitor them and let it be for some time before you can come to a diagnosis, okay? TMJ pain, muscular pain related to the masseter muscle, it's very close to your posterior teeth, it can mimic endo pain, but it's not. Trauma or parafunctional habits, again, need to be very careful and distinguish them for endo. Neuropathic pain or typical facial pain, trigeminal neuralgia, all those things, basically what I'm trying to tell you is try to differentiate between endo and non-endo pain. That's all. Okay. And vertical root fractures. Vertical root fractures, when diagnosed, if diagnosed the right way, the only treatment is extraction and nothing else. So again, they do not form a part of endo. Now, this is something that I can give you. This is another handout, not the surprise one, but another handout that I can give you that tells you the case difficulty and assessment form. This is a guideline basically that you can tick that, okay, it's a low difficulty or a moderate difficulty or a very high difficulty case. This will help you in evaluating what kind of, treatment charges or treatment modalities that need to be, done in order to do the case. So basically, it helps in explaining the particular case to the patient even better, right? Because not every case is the same. Let's face it, a central incisor obturation is not the same as an obturation of an upper second molar, with bifurcated roots or split canals at the apical end. It's not the same. So why should we charge the same, or why should the treatment time be the same? So we have to explain all these things to the patient, because he can be like, oh, that day it took only 40 minutes for the endo. When I went there, they did it in half an hour. And here you're doing it with 2 to 3 appointments taking, 1.5 hours each. So there has to be some sort of an explanation for what you're doing. And this form helps you in, putting out your thoughts and putting out all that information neatly. Okay. Last thing is planning. Now, this is what us as clinicians, we will do to alleviate or correct the condition that has been diagnosed, because in assessment we did that, and now we're going to plan our treatment. What are we going to do? Good record keeping provides evidence of the level of skill, the care, and the attention the patient has received. And each step in the procedure needs to be properly documented, like I've been trying to tell you all this while. So you need to do a proper tooth isolation with the dental dam, which is basic standard of care. It should be noted in the chart. All these small things, which clamp, when the clamp is not visible in the radiograph, you have to write it down that this was done, this was used, which file number I used, how many canals were there, all those things, all this is explained and documented very, very well. The prognosis, in fact, also is explained to the patient. The restorative recommendations that you have done, that, okay, this tooth needs an onlay, maybe needs a full crown, all this should be documented. Even the prescription that you're giving. So all this comes as a part of your plan, the documentation bit of it, okay? So this is how a proper, assessment form is going to be. Okay. You can see SOAP, and this is what I have described all this while. You have the chief complaint, HOPI, medical history, vitals, the clinical examination, extraoral, intraoral, radiology, assessment, and then the plan. So all of this comprises of your SOAP documentation form. Okay. Now, in endodontic therapy, you have either you'll have like an emergency endo that you need to initiate where you're doing the access opening, or it's an elective that you'll be doing at a later stage, Second would be you cannot do endotherapy, you're going to extract the case. This is your treatment part that I'm telling. And the third is a referral. You're not able to do this, it's beyond your expertise, I'm going to refer the case out. Okay. And the fourth is no treatment, which is also a very important modality. I'll explain to you with just a case in the coming slides, but basically, these are your 4 options of how you can plan once you have a diagnosis. You do endo, you extract the tooth, you refer the tooth, or you don't do anything, right? Okay. So the next is, I want to show you how I do my SOAP. This is how I write everything down. This is of a particular patient, the name, the age, a detailed endo assessment for a particular tooth, the subjective symptoms, the objective symptoms, what testing I have done. I have recorded every single thing, the assessment, the planning, and the treatment done as well. Okay. This helps me in the future. If I have any issue with this tooth, I have a very detailed record of what it came with, what was done, and how the patient responded. Even the follow-up will be mentioned in these documented notes only. So this is one of those SOAP sample forms you can think of. You can take a screenshot of this or even this. Okay. So let's come to case-based learning now. Okay. We'll look at two cases, very important. So this patient came to me with a continuous sinus tract in this area. Endodontic treatment had been done on this tooth 3 times and the lesion failed to heal. And the patient came to me saying that like they referred, Google, and they saw my name, and they saw the, expertise probably. And they told me that we came through Google because we felt like you could save this tooth, and they came asking if I'm an endodontist and all those things. They asked about my degree. They were very well informed. So they asked me if we can do a re-root canal on this tooth, which had already been treated 3 times. Okay. And there was this sinus tract which refused to heal. So as always, I do every retreatment with a prior CBCT. I do not treat it without a CBCT to understand where we are lacking or where we are going wrong, what needs to be corrected in my re-root canal. So this was a CBCT, and you can see the extent of bone loss that is there on the distal root. We initiated root canal therapy, and you can see within 4 weeks of intracanal medicament, the sinus had healed completely. So if you heal the tooth, if you do the right treatment from within, the tooth is going to heal. It's going to respond well. Finally, we finished the root canal treatment. There was some issue with the 7, which we treated, because you can see there is a silver filling over here that needed to be fixed before we put a crown for the 6. So we did that, and then finally I gave a ceramic crown for this patient, and you can see how beautifully this tooth is healing. And it's been, I think, 2.5 years. The tooth is doing very well, and the patient is also very happy with the treatment done. And it took us total of 6 appointments, but we were able to get what we wanted. This was another case, a case of trauma that came to me immediately. So the tooth 2-1 had extruded slightly, and the patient had fallen down in a road traffic accident. I didn't do too many tests on that day because the patient was in a lot of pain, and I advised a CBCT to know what is happening inside. The IOP revealed a proper horizontal fracture with 2-1, but I wanted to see deeper things, and what we saw in his CBCT report was that from 1-3 to 2-3, all the teeth had a horizontal fracture. Like this was the one that was most visible, but in fact, all of them had a tiny fracture line going across all the way till the from one end of the root to the other end. So you can see 1-1 is also fractured. Everything 2-1 also fractured, thin radiolucent line, and 2-2 was also fractured. So yeah, 1-1, 2-1, and 2-2 were horizontal root fractures. So in this case, because the fracture line was below the level of the bone, I decided to do nothing. We just splinted the tooth. We didn't do any endo. We didn't do any vital pulp therapy. Nothing was exposed. And mind you, after around 3 months of this patient's treatment of doing nothing, the tooth number 2-1 responded positive to pulp sensibility testing. So of course, we can't do anything on the day. We know that I did a cold test on the day, but I knew there was going to be no response because the tooth is so stunned to even respond. The pulp becomes shocked. It's in a state of shock because of the trauma that it has occurred, on the pulp. But it does not mean that it's dead. Okay, so you need to evaluate the pulp sensibility testing and the pulp status of the tooth as a baseline on the day of trauma. It's not going to depict anything. It's not going to decide your treatment in any way, just as a baseline. So I know that on day 1, I had no response, but on day, after 3 months, I had a response, which was a lot. It meant a lot, and the patient was very happy because they had gone to another place where they had suggested extraction of 2-1, right? So we saved this tooth without doing anything. Can you imagine? They were told extraction, implant, and the charges that they got, and for us to just do splinting and then just regular recall. Patient was very happy, and they were able to save the tooth. So basically, in conclusion, what I'm trying to tell you is that if you do a comprehensive endodontic exam It's going to help you. It's going to serve us to systematically identify the pulpally involved teeth, which is very critical for giving the kind of dental care that the patient deserves. The endo exam should be performed and the results have to be recorded in that SOP format before you initiate any sort of dental procedure. You need to have reliable information because that will improve your diagnosis, the treatment planning, and the patient communication, and even the trust of the patient in you as a clinician. It increases the possibility for the patients to receive more timely care. If the patient comes to you early with a crack, maybe you can treat it. If they come to you later, maybe you can't save the tooth. Now that needs extraction. So you're able to deliver quality care before it turns into something that, we cannot save. So I would like to end this webinar by saying that the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. So we need to be in a continuous, setup of learning, unlearning, and relearning new things. And I'm trying to do that. And I hope today with my webinar, you were also able to learn at least one new thing today. So I have a free handout for everybody today that follows the SOAP checklist. People can get in touch with me. They can follow me on social media or just DM me. I can hand out the diagnosis form to you. And I also have a particular consent form that I have made specifically for, it is different for each case, but there is a basic outline that I have. So I am happy to share that with you. In case anybody needs it, please feel free to reach out to me anytime and I'll be happy to guide you in any way that I can, even with any doubts that you may have related to endodontic diagnosis. I'm happy to, guide you with your cases or anything at all. It would help me and you also in turn treat some patient in a better way. So just get in touch with me and I'll share the same. Over to you,
Oh,
MedWorld Expo. Yeah.
thank you so much, ma'am. It was very insightful. So we have a few questions in chat box. So let us go to the questions, then we can close the session.
All right.
Yeah. So we have a question from Venkat. He is asking like, what are the most diagnostic dilemmas faced in endodontics and why do they occur?
The biggest, I think, dilemma in endo would be a crack because they're so difficult to diagnose. Especially when they come in your early days, you can't see it probably, you can't diagnose it well. And even if you send them for a CBCT, the CBCT is not equipped enough to deal with initial cracks, so they won't show up on a CBCT as well. So it's very, I think, diagnostic dilemma in endo would be for me a crack only because they're very difficult. And why do they occur? I mean, like dilemmas, I'm not sure. Are you asking why does a dilemma occur or why does the crack occur? I'm not sure.
Okay.
But yeah.
Yeah. We have a question from Rakesh. How can clinicians differentiate between reversible and irreversible puppets with greater accuracy?
So, as I told already, reversible pulpitis is going to be non-spontaneous, non-lingering, and there'll be no night pain. But with irreversible pulpitis, you're going to have spontaneity. It's going to pain on its own. Like the patient is sitting, he's doing nothing, not eating food, no cold water, nothing. And it starts paining severely. Okay. So that is spontaneous pain. It's going to be lingering. That means when the patient is drinking something cold or if there's a stimulus, the pain lingers even after the stimulus is removed. The patient sits like this, that is lingering, right? So that is irreversible. And the third thing is pain at night, because when the patient lies down, there is a change in the postural, blood flow, and there's increased pulpal blood flow. And because the chamber is already so constricted and the pulp is inflamed, there's no space to go, it's going to pain a lot. Irreversible pulpitis, pain at night. So I think these are the three things you can use to differentiate between the two.
Yeah. We have a question from Pavan. Good evening, doctor. What role do advanced imaging techniques like CBCT play in resolving diagnostic uncertainty?
Lots of it's difficult to answer in one go, but if I had to give an example, like the first case I showed you, so in that I took a CBCT. It showed me that the crack went deeper and was involving the furcation, so I knew that I can't save it with endo and I need to extract this tooth, right? And in the same way, the last case I showed you with the CBCT, there was a continuous sinus tract. Now if I didn't take a CBCT and the sinus was probably due to something else, probably a vertical root fracture, where I know that the tooth has to be extracted, then even if I keep doing endo, it will never solve the issue. So CBCT helped me in showing that, okay, it is only an infection and it can, be resolved if I give it another try and do a better job at cleaning the tooth and removing the infection. So CBCT helped me in, making that decision. It helped me giving the patient that opportunity that, yes, this tooth can be saved. So this is one of those examples.
Yeah, we have a question from Kumar. What are the limitations of traditional vitality tests, and are there better alternatives?
Yeah, the limitations would be so the best that you have is actually a cold test, which has like almost up to 98% reliability that you can reproduce the chief complaint. Okay, so cold test is your first thing that you will be going to. There are other pulse sensibility testing as well, like you have Doppler, you have electric pulse test, and all those things. But in my opinion, a cold test is the way to go. That is the best way. There are no better alternatives than a cold test. After cold test, my second go-to would be probably an EPT or a heat test. But in my experience till date, I've never required to go anything, further than that. Cold test is economical, easily available. Why would I look for other option when it's, reliability is so high? So yeah.
So we have a question from Kritika. What role does experiences versus objective testing plays in difficult diagnostic cases?
Does experience What role does experience versus objective testing play in difficult? I didn't understand the question. Are you comparing? You have to rely on objective testing. You have to see what you're being presented with. I will not go with experience. I will go with what the patient is presenting with. And if I'm able to reproduce the same symptoms with my objective test, I'm going to come to a diagnosis, and that is how I'll treatment plan. I will not base it on my experience. Ki, oh, that patient ke saath, it happened like this. So this patient also will have. Every patient is different. They present to you with different symptoms. Yes, you can use your experience to draw some sort of learning from it and
Please.
in case, but nothing goes beyond tests of each patient.
We have a question from Kavya. Could you share some real life case studies where the initial diagnostics turned out to be misleading?
Real life cases where the initial diagnosis turns out to be misleading. There's so many cases. Day to day, we see people diagnosing teeth with sensitivity and doing endo, right? So teeth don't require endo in all cases, and the patient has come to you with sensitivity, probably with some exposed or deep carious lesion, and then they end up doing endo, but the endo was not needed in the first place. Or like, and I can tell you maybe a tooth with a crack or a vertical root fracture where people are doing endo. It's not needed because the tooth is going for extraction. So, it's the initial diagnosis you're doing. The diagnosis is wrong, the treatment done is wrong, and that is why it's misleading. And then you have to go back whenever you see something is not being treated the same way, or the results that you expected are not coming the same way. You always have to go back to diagnosis. Okay, this is where I went wrong. And it is almost always diagnosis.
Yeah. And we have one last question from Tanisha K. Can you throw some light on pain or top post RCT?
Hi, Tanisha. Lovely question. So, yes, it's very important that people understand that there is going to be pain after root canal. It is a very normal thing. It's a small wound that has been created. It's going to pain after root canal. It's not something that it will just disappear. The only time we should be worried is if the pain is not decreasing. It needs to decrease after you initiate the root canal treatment or after you're done with the root canal treatment. So if after a day or two or even after 3 days, the patient is complaining that the pain has suddenly now increased after root canal, it has become more, there's a severe pain being developed or swelling is there, then you're dealing with a flare up. But if immediately after the root canal treatment, the patient next day complains of like sort of pain, it is slightly lesser than before, it is moderate, it is bearable, you have to put them on painkillers, of course, for a day or two. And after that, also, if the pain is not in a decreasing fashion, then you've gone wrong somewhere. But you have to inform the patient before they leave your clinic that you are going to encounter pain. These are the painkillers for it. And in fact, make it a practice that in your clinic, after the root canal is over, give the patient one tablet of painkiller in their hand, make them drink it immediately. So that when they go back, anesthesia wears off, painkiller has started acting, they are pain free for the next 6 to 8 hours. And then they take, they have their next meal and then they have another painkiller. So they're relatively pain free for the next day or two. And after that, if they still complain of severe pain, which is very unlikely, which means you're dealing with a flare up, that means you're going in the right direction. So the pain will decrease. It will not decrease immediately. It will not go to zero, but it will decrease. So it will be there. You have to explain it to the patient. If you tell it to the patient, he'll be more mentally prepared that, okay, I will have pain. The doctor told me, and they will deal with it in a better fashion.
Ma'am, we got another question. Maybe this will be the last question that we will discuss. There is no name for the user. Tooth with boneless and top positive. SHD, we always endo treated or just planning and scaling or curettage?
You have to, as I told you, you have to form that SOAP protocol, do the SOAP. It's difficult to tell just by reading bone loss and TOP positive. Why is the bone loss there? Is it due to a pulpal symptom that has caused the periapical lesion, and then the bone loss is happening? I don't know, right? What is the cause of this bone loss? Figure that out. Once you figure out the cause, you'll be able to do the treatment well. So figure that out. Do all the assessment, do the subjective, the objective, then the assessment, then the treatment. This is too vague to understand what is happening. I cannot tell with just this much information whether it needs to be endo treated or just planing, scaling, and curettage. I've not seen the tooth, whether does it have a carious lesion. If it's a clinically sound tooth, too much of information is missing. Lot of reading to be required.
Okay. I think we're done with the questions. And thank you so much, Dr. Urvashi ma'am, for your valuable session. And you have answered most of all the questions. And if they have any queries, they might be connecting with you on Instagram. So before I close this session, I just wanted to show my platform. How does it work and what would be the major advantage for all the doctors and medical students and healthcare professionals. So I'll just take 2 minutes before we close. So I hope everybody can see my screen. Ma'am, can you see my screen? Can you please just, yeah. So good evening, everyone. So I'm Nikhil. So I'm here from MedWorld Expo. So the screen that you're seeing, it is the MedWorld Expo landing page. So if you log into www.medworldexpo.com, so it is a global healthcare platform where you will be able to connect with manufacturers, distributors, and healthcare professionals like Dr. Urvashi ma'am, she's a doctor, and medical students, healthcare professionals like doctors, practicing doctors, or a nurse. Anybody can be log into our platform and they can create account for free of cost. There is no charges. So as most of them are healthcare professionals, I would like to showcase what would be the major advantage for them through our platform. First thing, you can browse different kind of latest advanced medical equipments in our platform. So you'll be able to find different manufacturers, distributors, and all the hospitals as well. If you come into network option, you'll be able to see healthcare providers. If I click on healthcare providers, it will redirect you to hospitals, doctors, laboratories, and others. So you will be able to access these things first, and later we are giving an option called events. In this events, we have option called webinars. So the way how you have attended this webinars, so the way the way you have attended this webinar, so you can able to attend different kind of webinars through my platform. So if you can see that we have upcoming webinars as well. So for every week, we do at least 3 or 4 webinars in our platform. So people who haven't registered for other webinars, please do register. We have dental related, we have other different kind of specialties. And if you can see, we have another option called blogs. So as a doctor, as a medical student, you can write blogs. If you can, like, based on any topic, or if you have any kind of questions, even you can put it over here. Most of the doctors, they will be able to answer your questions, or they will be able to help you out in different kind of topics. So I request Dr. Urvashi ma'am, or if you are free any time, I would I request you to write a blog on any kind of topic. So that would be more valuable who are coming into this platform, and they will be able to browse the things. Thank you, ma'am. And we have CME programs. So CME programs is for the people, most of the doctors and medical students. So it is credit-based programs. So people who are joining the CME programs, we will be able to give them the CME credits, where this will help them to renew their license. So this is one kind of advantage for you to join different kind of CME programs. And we have MedWorld blogs, insights, and news. So you will be able to access all the healthcare and medical news and insights across the globe. And we have medical communities. So if you are into dental, or if you are into any kind of other specialty, you can create a separate community over here, and you can gather the people over here, and you can network with the people. If you don't want to create any community, there is already few communities in the platform. You can directly join those communities, and you will be able to connect with different kind of people. As you are into healthcare and medical, so the major thing, all the doctors and medical students will look for networking. So MedWorld is a right choice for you to network with any kind of healthcare professionals. And we have healthcare journals, where you can post any kind of healthcare journals that you have written, or if you wanted to browse, even you can do that also. In the same way with magazines, you will be able to access different kind of medical magazines across the globe. So I'm not talking about domestic. MedWorld is all about global. So whatever you're doing, it goes across the globe. So that is the major thing that we are giving an advantage for you, all of you. And we have another option called career advancement. So most of the people who are graduating or post graduating, people look for going and like studying in abroad, right? So right from the application or right from the guidance, we will be the right path for you to guide you and go like cross the abroad. So everything we will be taking care right from application, choosing the hospital, choosing the college, choosing the specialty. So we will guide you from complete all the stages. So last but not least, so we have option called jobs. So if you can see, we have different kind of job opportunities in our platform. So we have separate team who is gathering different kind of medical jobs. So if you're going to the other platforms like Naukri and Indeed, these kind of platforms, so it is for all the categories, right? But if you can see in MedWorld, it is only for healthcare. So this will help you out to find out the right job for a right person, right? So I request people who haven't registered to the webinar and joined the session, please do register. And if you wish to to do any kind of blogs, you can do it. If you wanted to create a communities, you can create it. And if you wanted to network, you can do networks. And if anybody is interested to do upcoming webinars, please do let me know. So you can contact me on this number, or you can write an email to this email ID. So thank you so much for all of you for actively listening and being there till the end of the session. And before closing the session, Dr. Urvashi ma'am, do you have anything to say? Closing statement?
I wanted to ask one thing. I'm curious about the site since you mentioned so much. So, do
Yes.
you include psychologists as well?
Yes,
Like,
ma'am. Everything which is comes under medical and healthcare. So you can write anything.
okay, because I might have an opportunity for another individual, a psychologist, and I'll connect them with you so
Sure,
that
ma'am.
they can write blogs or they can maybe conduct a webinar with you people.
That's
So
really great, ma'am. Thank you so much.
yeah.
Yeah.
All in all, it was great doing the webinar with you. You guys were really good. You were on the point, and hosting was really great from your end.
Thank
So
you,
thank you
ma'am.
for having me, and thank you for giving me this platform to be able to share my expertise with all of you here today. And thank you to my participants. Also, like I told everybody that I would share the handout with them. So I'm just going to put it in the chat box for everybody who stayed till the end. And those who didn't get, I hope they can connect with me, on my DMs or my social media. But otherwise, I will share it here in the chat
Yeah.
box. Is it visible? I'm not sure if
Yes. Maybe you can drop your Instagram ID in the chat box. Maybe they will be directly texting you if they need any kind of assistance.
WhatsApp group that is there that I
Yeah.
can connect
Even I will
people.
download the file. If somebody asks me, I can directly give it to them. No
Yeah,
issues.
yeah, no
Yeah.
problem. But do you have like a WhatsApp group of the participants, of the dental participants in
No,
any?
I do have the registration list with me. I'll be sending to all of them. No problem. No issues.
Thank you. Thank you so much. Thank you so
Thank you,
much.
ma'am. Thank you so much. It was great talking to you, and it was a wonderful session. Thank you for being there.
Right. Bye
Thank
bye.
you. Yeah. Bye, ma'am. Have a good day.